use for the head of the pancreas. On the other hand, you can have another scenario where it's in the body, it's going towards posteriorly towards the vessels. There is no bowel involved in. There you can freely dose escalate, give, maybe 40, 50 gray in 5 fractions. And so basically it all depends on the clinical scenario of the relationship between the critical structure and the tumor itself in the body.
Okay. Thank you. Professor Mahadevan, we have now many more questions. In the clinic, how many fiducials do you use?
So in my CyberKnife practice, I generally try to get at least 3 fiducials. That helps us get both translational, rotational corrections. We generally used to do, we can get at least 4 because I'm worried sometimes one of the fiducials might move. But I do understand sometimes endoscopically it might be difficult to get more than a couple of fiducials. That's then we have to really look at give some time for the fiducials not to migrate, and look very carefully at the translational and see what the relationship, if a rotational shift is going to matter or not. And so just to short answer, I use at least 3, preferably 4.
Yeah. And how far do you place the fiducials from the pancreatic tumor?
Oh, usually we are able to place it in the head of the tumor. We never have a problem because our endoscopic ultrasound people, gastroenterologists, are extremely proficient in that. So much so that even at their original diagnosis of a case of obstructive jaundice, suspected pancreatic mass, when they go to stent the patient and get some cytology, they would automatically put fiducials in. If the patient comes back as metastatic disease, it doesn't matter. So yeah, we would generally put at least 3 fiducials endoscopically. And we used to do CT guided before. Nowadays, it's majority of the patients. Very rarely we do CT guided.
Yeah, we do the same. We also place 3 fiducials as close as possible to the tumor, sometimes into the tumor, and usually we place 3 fiducials. So then we have another question. What do you think of online adaptive radiotherapy for pancreatic stereotactic radiotherapy?
That's a great question. Online adaptive radiation therapy can help us in 2 ways. Number one, in tumors which are rapidly shrinking, for example, sometimes in head and neck cancers, it helps us decrease the PTV and the amount, and also allow us to maybe dose escalate. On the other hand, in the pancreatic cancer, where it will help more is maybe a look at the relationship to the pancreas and the adjacent organs like the duodenum and stomach on the day of treatment, and adapt to avoid them so that we minimize. So anytime we talk about adaptive and dose escalation, the benefit can be in looking at the tumor and escalating dose. At the same time, it can also help us in looking at the normal tissues and organs at risk and avoiding them very well, adapting to avoiding them.
Okay, thank you. Then I have another question for the MRI Linac or the Meridian. From GTV to PTV, they often use 3 millimeter margin. In our center, we use from some GTV to CTV 5 millimeter, and then from CTV to PTV 2 millimeter. I wonder, what is your margin?
So generally, I would use 3 millimeters of expansion from the GTV all around the tumor, except if it is abutting the duodenum or the stomach, or it is enveloping up to 25% of the circumference, then I would not give any margin there at all. Then that begs the question of what technique are we using? If you're able to use, cross-sectional imaging and look at the tumor and match it and treat it, then it gives a little bit of a confidence of it. But the problem with those techniques is there is still no way of live tracking in patients who have cross-sectional imaging during treatment. So that's where we need, on the other hand, if you use techniques where you're using good 3 to 4 fiducials, rigid body constrained, and you're able to track them, then you're able to confidently treat those people, right? So yeah, it's a question of what technique to use and how we are able to visualize the tumor and the normal tissues.
Okay. So I think we are now to the end of our very nice presentation and webinar. I all would like you to thank for your attention, and I hope to see you next time. Thank you.
Thank you very much, Joost. Thanks, Lisa, Lindsay, and all the participants. Thanks for taking time to join us today.